Welcome to the Nourish Child Podcast, a show about childhood nutrition, feeding kids, and dealing with the ups and downs of growing a healthy child. Here's your host, registered dietitian and childhood nutrition expert, Jill Castle.
Hey friends, welcome back to the Nourish Child Podcast. I'm Jill, and today I have a very special guest, a friend and speech-language pathologist, colleague of mine, who is on the show today talking about why kids won't eat and what parents can do to support their children. So research tells us that the incidence of pediatric feeding and swallowing disorders is about 20% in typically developing children and 80% in children with special needs. So how do you help these children? And how can we as a team of healthcare professionals do our very best on behalf of children who need a little bit more support with eating? So Cheryl is on the show to talk about all of this stuff with me. We have a conversation about that, but let me tell you a little bit about her. She is an ASHA certified speech language pathologist since 1987. She's also a certified lactation counselor since 2008. She is the founder of Gnosh, Inc., Gnosh. Gnosh, Inc. is a feeding and swallowing private practice and product developer. Cheryl, has developed the side biter and the mini biter therapeutic feeding and swallowing tool. But more importantly, she has dedicated the past 30 years to working with infants, children, and developmentally delayed adults in home-based and outpatient clinic settings using sensory oral motor-based feeding swallowing therapy. She often co-treats her patients with registered dietitians, physical therapists, and occupational therapists, and she has shared her knowledge at numerous staff education events in southeastern Massachusetts and at ASHA annual conventions. So it is such a pleasure to have this conversation with her. Just a note, I recently met Cheryl within the last year, and we've become fast friends in this stage of life that we're in. She lives a little bit around the corner from me here in Massachusetts. Not really, but when I'm in Marion, she's on the Cape. And so we're not too far away from each other, though we've never met in person before. We've done virtual conversations and telephone conversations, but she is a wealth of wisdom and knowledge. And I think you will get a lot out of this conversation. Here we go. I hope you enjoy it. And remember, not only can you listen to this on your podcast app, but if you want to see us in action talking together and see some of the products and demonstrations that Cheryl uses during this conversation, you can watch us over on YouTube. Okay, folks, here we go. Well, hello, Cheryl. It is so nice to see you this morning. And
Thank you for having me. Mm-hmm.
Yes. So I'm excited to talk to you today because we have become friends, collegial friends over the last, 6 months or so. We've had a lot of sidebar conversations. And I thought it would be really great to have you on the show just to talk about what it's like to be a speech language pathologist. And more importantly, since this is a parent listened to show, how parents can utilize speech language pathology, how they, what conditions might require it, what expectations parents might have for outcomes, and just get into the conversation around, this segment of healthcare that definitely dovetails with pediatric nutrition. But before we start,
sure,
tell everybody about who you are and what areas you specialize in, and so they can get to know you a little bit better.
Okay. Well, first of all, Jill, I wanted to say that you have helped me over the last probably 15 to 17 years.
Oh,
feeding and swallowing therapists, whether they're speech pathologists or occupational therapists, need a skilled pediatric dietitian on their team if they're going to be working with any child that has an altered eating pattern. And back that many years ago, at my work, we did not have a staff nutritionist. And I was searching on the web to find somebody that could help the parents and me, because I know my scope of practice. I'm not an expert in nutrition. My job is to help the child chew and swallow or accept the foods, but the menu and the actual supplementation is absolutely critical from a skilled dietitian. So I found you and I joined your newsletter and I read every single one. And the one that really spoke to me, I gave to the parents. And from there, I, of course, was trying to get a dietitian on staff where I was working. I knew better that I needed to stay in my lane, and I wanted to bolster the nutrition of this growing body and brain that I was working with. So you have helped me so much. And then when I noticed that you're at the bottom of one of your posts, it said Marion, which is near me. So that I was like, oh, she's so close, because you were in Connecticut then.
Yeah.
Anyway,
Yeah.
my name is Cheryl Pelletier, and this is my 37th year as a speech language pathologist. I always worked with adults and children with dysphagia early on. The last 25 years, I've dedicated just for feeding and swallowing. And I became I never called myself a specialist because I felt there was so much to learn. And I have worked with occupational therapists, physical therapists, endocrinologists, GI professionals, and most importantly, dietitians that need to be registered and really well-versed in pediatrics. There's a lot of people out there that hang out a shingle and they say they're nutritionists, but in my view, I need a registered pediatric dietitian who understands about feeding disorders. Now, that is something that is very, it's a subset of specialty. I've worked with dietitians before that gave the parents a list of foods that the child ultimately should be eating. And that sounds wonderful, but if they cannot chew and swallow it, or they have a restricted diet and only eat mac and cheese and Ritz crackers and 2 gallons of milk a day, that is where the skilled speech pathologist comes in. The reason that speech pathologists got involved with feeding and swallowing is because in our background, we are trained in all of the muscles of the face, the tongue, the throat, and we are trained in dysphagia, which is the swallowing disorders. Mm-hmm. Occupational therapists come into play when there's more sensory barriers to eating, and we overlap as a team. That's the ideal team if you have a child that maybe was slow to progress from bottle to puree to diced foods, and their continuum of feeding development was interrupted somehow. It can be interrupted by medical problems, by social, emotional problems. It can be learned behaviors. Mm-hmm. In the last 10 years, and we've talked about this, you and I, in the last 10 years, the actual feeding disorders in terms of chronic rejection, food phobias, refusing to sit for meals, losing weight, dropping foods that kids used to eat, just making their nutrition so precarious. In the last 10 years, it has skyrocketed.
Why do you think that is, Cheryl? Why in the last? Is it related to
theories? Yep, I had, and then now this is just off the top of my brain as a mother and a grandmother, and as being in the field for a long time, and observations. I feel like that it's a perfect storm. Mm-hmm. Our country just went through a major pandemic. We were just trying to survive. Families they're under the gun in terms of both parents' work. Mm-hmm. The structure of the day is different than it was even 10 years ago. The exposure to what parents should be doing on social media is out there, which is quite confusing at times. That's why a team approach is really helpful to maybe redirect or to reel a family in to try to help them navigate a feeding disorder. The statistics are quite staggering in that feedingmatters.org, which is a great resource for families, they also do some research and publish. They are saying that 20 to 30% of typical developing children have some phase or type of difficulties relating to food. That's pretty high.
That is very high.
When you throw in any kind of delay. Now, what I'm speaking about is a child that maybe was delayed in rolling over, delayed in walking, physical delays that can manifest with having problems moving your jaw, tongue, and lips to eat enough and have stamina enough to swallow the foods that they need to grow. And then maybe they need a bottle for a prolonged period. I feel like more and more children are allowed to walk with food and not sit at the table. And it's sort of, like I said, the perfect storm. Maybe you have a delay in oral motor, meaning that it's hard for you to take a bite of meat and chew it adequately, but Ritz crackers are easier to chew. So they have prolonged, easier, I'm putting it in quotes because, there's certainly foods that take longer to chew than others. The invention of pouches, I think, has been awful. I'm not against pouches. It's just that it keeps a child on a liquid diet. Purees are a liquid. They're just thicker. And they're easy to just pass back in the van. And, little to go packages have made snick snacking, I call it.
I love that.
Snick snacking, which that interferes with the hunger dynamics. Kids have to be hungry to be able to try that broccoli or cheese and crackers or apple with peanut butter, which are all quite complex. And so if you miss out on that window of time to chew and swallow these foods that break apart, they're complex, some are bitter, some are sweet. Forget about soups and casseroles. So I think that happens, and those things are not bad and they're great. But when they're overused, it keeps kids, it's like screen time. If it's overused, then what is the child missing? They're missing soccer outside. They're missing playing with their friends.
Right.
And if you're eating in front of the TV, then you don't really pay attention to what your tongue and lips and jaw and swallowing have to do.
Right.
Some kids are traumatized because maybe they weren't paying attention and they choked on a piece of apple, and then they're all set. They're not going to have apple again. They're done.
What about prematurity, Cheryl? Because I know, back in the day when I was a clinical dietitian in Boston working at Children's Hospital and Mass General, we had the NICU, and the NICU was always full. I think we had a 30-bed NICU. And again, this would have been a couple of decades ago. We're showing our age here, Cheryl. But the NICU was always full. And the babies were more and more premature as time went on. And I'm curious as to your perspective on, is prematurity contributing to these potential delays in learning how to eat? I like to call it learning to eat because I know it's the sensory, it's the mechanical, it's the behavioral, it's all of it.
It's also cognitive. And two things I want to say. My kids always tell me, Mom, when you say back in the day, that makes you sound I say it all the time. And airwaves, they hate that. So back to prematurity. There are more and more children that are living after extreme prematurity or extreme heart defects or some kind of medical barrier to their entering the world and going right to the breast or bottle.
Yeah.
So you have an interruption in the natural flow of the neurological wiring of I'm born now, I'm hungry, I need to suck and I need to swallow. And there's an interruption, whether it's an NG tube or a feeding tube in the belly, called a G tube. And that is a disconnect neurologically about, oh, I now don't know what to do with my mouth.
Yeah.
And absolutely, kids that are born too early are not meant to be eating right away. So it becomes this difficulty with the whole experience. Now, experiences are what teach us what to do. Some people ski, some people don't ski, some people eat, some people can't, yeah.
Right.
So, but it's a natural thing for somebody that's done it since they were born. And it's unnatural, just like if you learn to ski when you're 30, and it's unnatural for your legs to be doing these things.
Yeah.
But you have all these muscles of coordination paired with breathing. Breathing takes precedence over anything. So when you're born early, your lungs are immature and you need to breathe to live. You don't need to eat to live because they can supplement you by tube. So they're just, struggling to stay alive. And also with the complications of being early, you have brain bleeds, you have GI issues because you're not meant to be in the world eating yet. You're still supposed to be fed through the placenta.
Yeah.
So absolutely, there's more that they're saving, which is a blessing, but then they need a good team of therapists and dietitians to support them in nutrition.
Yeah. And then the other category of kids are the ones who may have neuro differences, like children on the autism spectrum or with ADHD. Are you finding, I know that the percentages or the incidences, the statistics around those conditions have increased over the last decade, at least, probably 2 decades. Are you finding a correlation with that population too, in terms of having more need for support around eating and feeding?
Yes. So let's talk about autism first. Often the treatment kitchen or early intervention, red flags, when the child is under age 2, sometimes they're about between 12 months and 15 months. And the family is saying, well, Johnny can run and walk and he's doing all these things, but he doesn't eat well. And that's the first stop in their identification that there may be some sensory delays, there may be some rigidity in the cognitive learning style of this little person. Oftentimes it's around the first birthday when everyone's excited that they're going to have cake. And they've put cake, they've never seen cake before. And they put cake in front of this child and the child goes, and, they're feeding them cake and they're gagging and they don't understand why. They go right to an occupational therapist or a speech pathologist, whoever the physician sends them to. And it's really a red flag for why are they not progressing? And from there, you're absolutely right. It is a combination of sensory differences and the need for sameness. Some children on the spectrum really feel most comfortable when things stay the same and they don't want to change from the bottle to a cup, or they only use one cup, or they only drink one brand of milk, or they only eat one brand of crackers, and that's it. Even if they used to prior to age 1, he was such a good eater and he used to eat all fruits and vegetables, and then learned that there's not sameness in the apples. They're all different. Some are mealy, some are crunchy, some are sweet, some are sour, and they're all set.
Yeah.
But in a package, they know that the fishy crackers are going to be the same.
Yeah.
So as far as, and also with that whole spectrum, so the reason they call it a spectrum is ADHD is actually a normal or typical, I should say, we're all on a spectrum.
Yeah.
So in autism, it's the attention span of, it's time to stop playing with the trains and airplanes or the screen time and actually focus long enough to eat. So they don't like to be contained. They feel better on the move, which interrupts our feeding schedule that we want them to have. Parents get nervous, so they give them the bag of fish crackers and the bottle, and they go and they're happy that they ate that.
Yeah.
ADHD is the same way in terms of their mind is working so fast and they have so many interests, and food sometimes it gets in the way. They don't want to stop.
Yeah.
They don't like to be contained in a seat. They need maybe the sensory support of their feet, but they're at the age where they don't fit in the high chair and they don't fit in adult chair. That's why we call on our friends, the OTs, to help us with positioning and seating. Mm-hmm. And that's where we overlap with trying to get the ideal position with less distraction. We want modeling from the family of how do you eat? Yeah. Sit down and, show them this is how I use my fork, or this is how I take a bite of chicken or pancake. And that is interrupted with a child on the move because they won't sit and watch you.
Yeah. So I'm imagining that there are some parents listening to this episode right now and saying to themselves, I think my child might need some extra support in this area. So, what does a parent need to do if they think their child needs more support around eating? How do they go about finding that support? Is that support easy to find? And what should a parent expect in terms of outcomes from that kind of support?
Okay. So first of all, parents are the experts on their child. You know exactly what's going on. The first thing that I recommend is take a little data, take a week and write down what your child actually eats and the behaviors around it. Like, what is happening? Is it that they're having trouble sitting? Are they gagging? Are they tantruming? What is happening? Yeah. And so that's one list. Then you're going to, so it's what they eat, what is happening, what your response is. What are you trying? The reason I like this is because this will get you help so much faster. You don't want to have somebody tell you something you're already doing. So write down your strategies and what works and what doesn't work. It's so important.
Can you give an example of that, Cheryl?
Yes. So, for example, we try everything. And the first time when I meet a parent, I say, I know that you have tried everything and you are frustrated and it's not your fault. I know that you've done everything that you can do. And so an example would be, I put out 6 foods that I know the child eats, and I turn on their favorite Paw Patrol, and I walk away and I don't make a big deal, and they seem to eat. Yeah. But after a while, it doesn't work. It works at first, and that's great. But then you have a grazing child that grazes and is never hungry. So that's an example. So the next stop for the parent would be go and have a heart-to-heart with your PCP. Sit with the pediatrician and explain, have your little binder there, because usually medical professionals love data. Yes. They like to see it. And what you don't want is them to say, it's a phase, he'll eat when he's hungry. Please don't do that, because the strategies that you're going to learn with a skilled dietitian and a speech pathologist are things that could nip it in the bud. So many parents say, I went to my pediatrician so long ago and we thought they were going to get over it, but they didn't.
Oh, that's my experience too. I've heard so many families say that, and they get frustrated, and that's a lost window of time.
And your frustration is making stress. And when stress happens, it quells appetite.
Yeah.
And when everyone's upset, I don't know about you, but when I'm upset, I cannot eat.
Yeah.
So after that heart to heart, and just say, don't ask, tell your pediatrician, I need help. I need you to refer me to a feeding team.
Yeah.
And you can Google it. Google is a great thing. And find out in your local area if there's a hospital outpatient clinic, if there's a private practice, if there is an early intervention program that has a feeding team.
Yeah.
The evaluation would be having a team take a look at how is your child actually chewing and swallowing. Are there food allergies? Are there some constipation?
Mm-hmm.
What are all of the barriers that's going into why the child's not eating?
Mm-hmm.
The SOS program, which is the Dr. Kay Toomey program,
Mm-hmm.
I love her take on feeding disorders, and she uses an icon of an iceberg, and the tip of the iceberg are the things that the parents are reporting to us.
Yeah.
Underlying that in the ocean, in the abyss, are lots of other things that we need to kind of take a look at to rule out. We're not looking for problems. We're looking to rule out problems that could manifest in why a child can't sit. Here is an example. Do I have time to give you an example?
Yes, please do.
Okay. This is such a great example. Little boy, 3 years old, would not sit ever at the table, which is fine. We did up on knees, we did whatever. And he seemed to bounce a little bit like this when he was eating. So we tried different things, different chairs. We were looking at the underlying in the iceberg, right? Finally got to GI. The gastroenterologist found that he was really full of stool.
Yeah.
He had so much BM that he was having trouble passing that. So his whole system was clogged and his belly didn't feel hungry. But even more than that, he could not sit because it hurt his little bum.
Aww.
And so once we got him
cleaned out,
he could sit.
Yeah.
So, you don't want to punish and take away, TV and different things until you have ruled out all the barriers that you can, because he couldn't help it.
Right. And so what I hear you saying is that for parents who are listening, there may be things going on that are very not obvious. And with a team approach, that team is going to look at medical, behavioral, sensory, the entire picture to figure out why. Because children are meant to eat.
That's right.
Right? We are all meant to eat. And so when a child isn't eating, it's on the medical and speech and nutrition and occupational therapists to come together and figure out why. Like, what is the thing that is prohibiting this child from eating?
Yep. It's never one thing.
It's never one thing. I agree.
There's so much guilt on the parents. I just have to say to you, you have to give yourself a break. You are the best parent for this little child. And even though professionals are going to say, let's try a certain thing, you have to take what works for you.
Right.
You have to feel that it's something that works for your family structure and style.
Yeah.
And the suggestions that are made no one is judging. Trust me, they're here to help you support your child and feed your child. And you are the boss. You're the center of this. Don't ever let anyone, speak to you like that they have all the answers. And so I feel really strongly about the level at which you're feeling like you did something wrong.
Right.
You didn't. Your child has some other things going on.
Yeah. And I just want to add on top of that too, oftentimes, and this has been such a traditional thing too. I remember way back earlier in my career, it was always like, what has the parent done to cause this problem? And what we know now is that feeding especially, and even parenting generally, but feeding especially, is so reciprocal. Your child presents you with a cranky attitude today at the table and throws a tantrum, and you react to that. And then your child reacts to your reaction, and you react to that reaction. These things sort of, they're never one thing. It's never the child or the parent. It's such an integrated, dovetailed, reciprocal relationship that I want parents to recognize that, we're always reacting to our child. Whatever our child is putting, on the table for us, we're reacting to that. Our child is reacting to us. And so sort of being able, like you said, give yourself a break, pull back a little bit, and just recognize that, I believe all parents have the best intentions, and they're doing the very best they can do given the situation that they're in at a particular point in time. And I always feel like for parents who are struggling with a child who's not eating well, that they inherently know that there is something wrong. Just to, emphasize what you said, if you think there's something wrong, there probably is something wrong. Like, don't doubt yourself. It's the same with an eating disorder. If you suspect that your child isn't eating on purpose, you're probably right. And so just tap into your instincts and know that there is support out there. And just to follow up on that third piece of the question, which I know I asked you 3 different questions in one question mark, what are the outcomes that parents can expect from working with a team of professionals to help their child with any kind of feeding disorder?
Excellent question. When I see a family for the first time, I kind of break it down into phases.
Mm-hmm.
I say, okay, we're going to use the power of 3. We're going to take 3 months to investigate and to see what will work, investigate the underlying barriers, because we're ruling things out.
Right.
And we're going to be supporting what your culture is in your home, what your family style is.
Mm-hmm.
We want to make things calmer and happier in your home.
Mm-hmm.
And with that could be some stress reduction, could be some cooking activities, could be making friends with foods that are very easy to look at, not too sticky, not too whatever, maybe. And as far as dysphagia, meaning chewing and swallowing problems, we may want to go ratchet back to textures that might be helpful to then learn forward. So we're looking at texture, we're looking at variety, we're looking at food flexibility, we're looking at the medical aspects, and we're not going to push too hard. It's going to be relaxed. It's not going to be, well, we need to do all these things, because it's a process that has phases in it. And if you've ever tried to change something in your life, exercise more, stop smoking, do something that required a habitual change, eating in general, it becomes habitual. We have our own little habits. Some people will say, I don't eat breakfast. I only have my coffee. Then at 10 o'clock, I eat. So we have these rituals. So anytime you've tried to change anything, it takes a couple of months. If you ever tried to lose weight or stick to the gym, or, your New Year's resolution. So give it some time. Your child and your family have been invested in this style of eating for many, many months. So there's no quick fix. Mm-hmm. I wish there were. I wish I had a magic wand. I usually use a straw and say, this is my magic wand. Poof, where it's all done. But it's a process we have to look at in other environments. Where is the child eating? School, daycare, grandma's house. Maybe the family shares custody. Maybe they eat better at one place and not the other place, and then everyone feels bad. you don't have to feel bad. It's a structure that needs to be supported, and supportive change takes time.
So phase 1 is about 3 months. Then what happens in the next phase?
Good question. So the next 3 months is really identifying what those barriers were doing to the family meal times. Do they need some medicine to help them to toilet better? Do they need some sensory support with OT? Maybe behavioral support with a home behaviorist. Maybe it's that they need a dietitian to sit down and come up with a plan of menu and supplements to help the child feel better. And maybe they don't need speech therapy right away, or maybe they need a neurological workup to find out if there's a syndrome. It's not all happening at once. It's okay, so we see this, now let's take care of that. At the same time, we're moving into what strategies do we know as a feeding and swallowing therapist that helps right away? Changes in textures, advancing in food exposures, advancing in positioning at the table, changing the environment, removing the toys. There's just a lot of things that we can do to support the adequate learning, like you said, the cognitive piece, and giving that family the strength to stay on a sort of a new ritual, building a new routine. And that's that phase.
Yeah. So can parents expect that their children will overcome these feeding barriers?
Absolutely. Best job in the world. I think I have the best job in the world because kids and families make so much progress, especially having an open mind. That's actually one of my phases, talking about we have to open our mind to the possibility of a new cereal or a new cracker or a new cheese. So being open and being adventurous and throwing away some of the things that maybe we learned from our parents.
Yeah.
Like you can't have steak for breakfast and you can't have cereal for dinner.
Right.
Like in my world, in your world, food is food. Wherever it comes out, we're excited that it's being eaten.
Yes.
So that's kind of a fun fact. And kids and families do so well.
Yeah.
And they might need doses of feeding therapy. I talked with families like, okay, let's do twice a week for 3 months. Then after that, let's go to 1 time a week. Let's go to twice a month. Let's go to once a month. Let's go to once every 3 months. Let's take a break. So I dose out what the support needs because I want the families to know how to make food friends for a lifetime.
Yeah. I do the same with nutrition therapy. It's, oftentimes in the beginning, it's more intensive. It's every week. And then we space it out. Once you see the confidence is up, once you see parents, knowing how to navigate feeding their children day to day, and they have all their toolbox, they have the tools and the strategies that they can start to whip out. Oh, this one's not eating that. Well, that's okay. We'll try, this other food. We have just this buoyant list of opportunities and options. The goal is not to need a dietitian or a feeding team or a speech language pathologist for the rest of your child's life. That is not the goal.
No.
The goal is to help children overcome these, limitations, barriers, obstacles, whatever you want to call them, and move on with life.
Yeah.
Right.
And it's not to eat every food. The other thing that I say to families is it's not to eat every food. If you can learn to accept or to chew and swallow, I defer to the dietitian. The whole point is nutrition, the whole point. So clinicians that are new at feeding and swallowing, I need them to really realize that the whole point is getting adequate nutrition. If that means that the child eats 5 fruits and 3 proteins and whatever the dietitian says, that's sustaining them. Doesn't mean they have to eat kiwis before their discharge.
Right.
That's my goal is usually 10 new foods in general.
Yeah.
And then I ask always, what did your dietitian say? What would they like you to be eating?
Right.
So if they have some, if they need more calcium or something, then there's a list of foods that the dietitian gives to the family that I want that information so I can train this child to chew and swallow it.
Right.
And to accept it on a routine basis in all environments.
Yeah. And I'm of the same philosophy. Your child doesn't have to eat everything under the sun. I don't eat everything under the sun. It's okay if your child doesn't like or eat certain things, but we want to make sure the diet is diverse enough and showcases enough variety so that all the nutrient needs are met. Your child's growing well, and we don't have to worry about some deficiency creeping up and showing up 2 years down the road because this diet has just, gotten so poor. And for parents out there who think, oh, my kid has always been this way. And I just want to say from a nutrition standpoint, we do have documented case studies of scurvy, which is a vitamin C deficiency, in children who are extremely picky. Like when you don't eat fruits and vegetables for years and years and years, and you don't take a micronutrient supplement, you can develop medical conditions that are problematic to your child's health. You can develop a vitamin D deficiency. You can develop a vitamin A deficiency. And we have case studies of this. So it's, while there is this looming, we do want an adequate nutrient rich diet. That is the goal. But at the same time, it's not to scare parents and say, oh my gosh, my kid is going to have this. It's very easy to avoid those outcomes with a little bit of attention to feeding, swallowing, nutrition, sensory, all of the support that, a team of professionals can provide these children.
Yes. 2 things I wanted to say. When people say behavioral feeding disorder, I wanted to speak to the parents in terms of that doesn't mean that your child is thinking in their head, I am going to be a bad boy and I'm not going to eat for you. That's not what it means. It means that there's something emotional happening that is preventing them from enjoying or feeling comfortable. I love the word comfort. We want to build comfort surrounding foods for so many reasons. And it could be a level of anxiety. It could be a level of just lack of experience. Food comfort translates to a lifetime of being able to go to a wedding or going to a birthday party and partaking in what other people are eating and enjoying the meal together. And, we all go to events and there's certain things that we put on our plate, and that is our right, responsibility, and joy. But if you're not comfortable with any of it and you don't go to any of these things, it puts you again at another barrier. So supporting your child wherever the barriers are and teaching them strategies like, I don't know how to rock climb, but if somebody threw me a rope and showed me some strategies and I held on really tight, I probably could figure it out. But without the rope and without somebody guiding me, I would be stuck. So that's the whole idea behind the team.
Yeah.
And it is a process. It would take me a long time to climb that mountain. And it doesn't mean that any one thing is not working. It just means that kids need more time sometimes.
Yeah.
And maybe there's some barriers that we haven't checked out yet.
Right. All good stuff, Cheryl. Yeah. All good stuff. What, as we wrap up this conversation, a couple of things. I know you're an entrepreneur also, and you've developed a product for adults and children who are having difficulty with texture. Am I right? And it's called the Side Biter. Can you talk about that just very briefly so that
Yes,
parents might be able to tap into that if they feel it's a good fit for them?
So I guess the best thing is I'm going to give a website just because it explains, and I know we're short on time. Thank you for mentioning that. So my website is www.sidebiter, like on the side, .com. I developed it because I worked with a lot of children that had physical problems chewing and swallowing. You mentioned prematurity and some of the delays that come with that. Just like somebody could be delayed in walking or writing, their mouths didn't work properly for speech or for eating. And they had already grown teeth. So, there's lots of toys, teething toys and things for babies. I was running into older children that really needed the sensory oral motor training to progress from liquids to diced table foods. So I invented a tool that you can put food in that's linear. Actually, I have one. I'll just show you what it looks like. It's hard to describe. So you put strips of pizza in this, and you can see my tongue going to the side. Well, a lot of our kids with cerebral palsy or other issues with chewing have a tongue pattern that does not help them learn to eat pizza. Mm-hmm. So also I worked with older adults that had Down syndrome, some other medical problems, and it was very difficult to safely transition them from a liquid and puree to diced foods. And the exercise that they get with actual table food from their families was miraculous. I've since made one that's a little bit smaller. This one is called the Mini, and it's for babies and children with smaller mouths, kids that have syndromes that have oral motor and swallowing problems. However, for picky eating, I have a level of this that has no holes in it, so no pizza comes out. And how I use it as a barrier tool to help kids understand what it would be like to crush an apple, but nothing goes in the mouth right away. So they have an opportunity to smell the apple, learn about the apple, cook with the apple, and then bite it without having the juice explode in the mouth, which is quite frightening to a child that has sensory problems and only eats Ritz crackers.
Yeah.
So that's why I invented it. It's not for every patient. It's designed to be used with a medical professional, such as an occupational therapist or a speech pathologist with goals in mind. And it's designed as a bridge tool to help bridge the gap. And that's what that is. Thank you.
Awesome. Wonderful, Cheryl. Well, I appreciate you so much. I appreciate the work that you do and are doing. I'm so impressed with just your ingenuity also and your wise advice. So thank you so much for coming on the show. I will include the links to Feeding Matters, Kay Toomey's SOS, sidebiter.com, so that if you are a parent listening and you want to read more about this, make sure you head to YouTube. The video of our interview will be up. You'll be able to see Cheryl with her quotes and her tools. And if you're listening on the podcast, you will be able to find these links in the show notes. So thanks, everyone. And thank you, Cheryl, so much for coming on the Nourish Child podcast.
Thank you so much, Jill. I appreciate it.
Thanks for listening to the Nourish Child podcast, where the #1 goal is to help you grow a nourished child inside and out.